Hey, it's Dr. Sebastian Gonzalez. I'm with Mike Jablon. We're going to do an ultrasound demonstration today. And if you listen to the podcast, which if you haven't, it's at p2sportscare.com/podcast. You can listen to it, and we talk all about knee ultrasound diagnostics and how useful it is for finding things such as runner's knee and IT band syndrome, even meniscal tears you can find with it. So Mike is going to be the expert with it, and he's going to show you and just guide you through it all. So if you never knew that you can actually see this kind of stuff on an ultrasound, you thought MRI was the only way, this is going to be a really, really good video for you. So listen to the entire thing. Go ahead, Mike.
Okay. Thank you, Dr. Sebastian. Thank you, Dr. Sebastian, to have me here. Welcome everybody today to musculoskeletal ultrasound of the knee. This is the same ultrasound that everyone's familiar with looking at babies, looking at the heart, blood vessels, same exact technology. Only today we're going to be focusing in particular on the knee. And one of the greatest advantages of ultrasound is the actual point of care, being side by side with the patient and being able to look right in, following symptoms and taking it from there. If you notice, the patient is sitting in the chair and I'm right here and I have his leg across me. This is a great way to be interactive with the knee. So we can maneuver things around as needed. And we're going to begin looking inside immediately along the inner part or the medial part of the knee. And we get an instant view. So when we take a look inside with this transducer, we get an instant view. Oh, go.
Just back up slightly.
Oh, sorry.
There you go. Go ahead.
We can immediately look inside and see the medial compartment or the medial joint line of the knee. And we get a beautiful, this dome right here is the medial femoral condyle. And we can see the spacing in between the joint. And in a matter of seconds, we can outline the medial meniscus. And there's a lot of information that we can determine right off the bat. Number one, how much joint space is there? Oftentimes, there'll be osteoarthritic changes in a knee, and we'll see bone to bone or different levels of degeneration immediately. In this particular case, we have a beautiful view of a wide open knee joint and a very, very nice intact meniscus. And if you notice, we're doing it instantly. So we have the transducer in hand, which is an extension of your clinical exam, and we go right inside and look immediately. And please note that ultrasound is 100% safe. There's no radiation. This is using pure sound waves, and there's absolutely no side effect. We could do this all day, and there's never been a reported contraindication. So we can not only take a look inside, but we can maneuver the knee, and we can look at things and see things in motion. So as we're moving the femoral condyle, we can see the articulation with the meniscus and with the joint. So this is step number one. We're looking into the joint. The next thing we want to know is, how's the medial collateral ligament? The medial collateral ligament is a strong ligament that we can palpate. And you might palpate and feel that there's an area of point tenderness. And again, the ultrasound transducer goes right on the spot, and we can take a look at the medial collateral ligament. If you notice on the screen, it's this big thick band that's kind of coming across, almost like a suspension right across the back of the joint. And we can see the fibers of the ligament. We can see that it runs in a continuous pattern from its attachment up top. And we can follow it down all the way to where it attaches down along the tibia. So a common injury in the knee is a medial collateral ligament sprain, a strain, or a tear. And if you're wondering that, you can take the ultrasound transducer and confirm it instantly right on the spot and rule it out from other common injuries such as a meniscal tear. It gets very difficult to differentiate between a medial collateral ligament injury and a meniscal tear, especially if it's acute, if it just happened. So ultrasound gives you the instant information to make this decision in your clinical assessment. So the medial joint line again consists of establishing the condition of the joint, taking a look at the soft tissue such as the medial collateral ligament and the medial meniscus, and then we can bend the knee up like this and move on to our next stop.
So with something like that, usually people will, they'll try to get an MRI to, so is this just as good as an MRI? I know we talked about it on the podcast a little bit.
Yeah, each tool has its own advantage, and the MRI takes a very beautiful view of the knee, and that a layman, a person off the street can look at an MRI and get a feel for where things are, whereas ultrasound takes a little bit more training to understand it, but each is valuable in its own way. Ultrasound's advantage by far is the dynamic assessment of the knee, whereas in MRI you're laying there in a completely still position. Ultrasound allows you to bend, to put a little stress. So let's say, for example, our next stop with the knee is a patella tendon, and the suspicion is that there might be tendinitis, but maybe there's a tear. Maybe there's a small, moderate, or large size tear, and you're just not sure. So you palpate it, you get your idea of what you think it is, and right on the spot, you get right in there with no radiation or anything, and you get a beautiful view of the patella tendon. And the trick is to be able to understand the anatomy, understand where it is, and then understand ultrasound to create an image of that, and you can determine right away the status of the structure that you're looking at.
So I got a normal one there, right?
Yes, you do. So far, so good. So far, you're checking out okay. You have a nice patella tendon. It's threading or feeding in nicely into the patella, and it comes all the way down. It attaches down here to the tibia tuberosity, and it looks really, really nice. There's a common condition, a growth plate disorder called Osgood-Schlatter's disease. Young kids will develop this, and ultrasound shows that beautifully, where the margin of the tibia tuberosity becomes fragmented and irregular, and with ultrasound you can instantly see that. Ultrasound is also an amazing advantage over the MRI in the sense that we're doing it on the spot at the bedside. MRI is an expensive test. Oftentimes you have to be sent out either to the hospital or to an imaging center, and there's a process involved to get it back and get the information. Whereas ultrasound, we're in the clinic, we suspect something, and we just get right in and look right on the spot.
Yeah.
So that's one of the main advantages of ultrasound.
Well, and definitely on kids too. Like if you don't want to expose them to radiation, it's a benefit to just do this real quick and just see what's going on there, right?
Yeah, exactly. And it's, with no disrespect to MRI, it's incredible technology, and it's an amazing tool for when it's needed. And a lot of times ultrasound can come up short, and we're just not sure, and we say, okay, let's progress and step it up and bring an MRI in and see what they think. So it's not really in any way intended to replace the MRI. It just is a new tool to be used at the bedside that can take us in that direction. You might not need the MRI if we get a good enough view with ultrasound, and oftentimes we do. And then on that note, a lot of times the MRI misses certain things that could provide a new set of challenges. Okay, so this is patella tendon, and we're looking at it again from its proximal attachment here on the patella and kind of following it down to the tibia tuberosity.
So what's all this down here then?
We're looking behind the patella, we're actually looking inside of the joint. So some of the things that we can see behind the patella, and this becomes interesting because there's a fat pad called Hoffa's fat pad, and you can almost palpate it, you can palpate it, it's right behind the patella. And there is a condition where that fat pad becomes irritated and chronically inflamed, and you can get a condition called fat pad syndrome, and it's a commonly misdiagnosed problem, and ultrasound gets a really good view of the fat pad, which you can see this mixed pattern of signal in there. Another advantage, when we'll talk about in a little bit, is knee injections, and it's very important to know where this fat pad is because we want to stay deep to that when we do knee injections, because the fat pad is known to be highly innervated and it can be very painful if a needle goes into it, so we want to stay deeper to it. But we'll talk about that in a little bit when we go to...
I'm glad we don't have any needles here then.
Yeah, no needles, no needles, thank God. So that's what we're looking at behind the patella. We're looking at the Hoffa's fat pad, and also deeper down into the screen, we're looking into the anterior cruciate ligament. Now, this is something that ultrasound is very good to red flag, and then we bring in an MRI if we need to really, really confirm an ACL tear. But ultrasound does a great job at red flagging a possible ACL tear. And the first thing we would see, and we saw one today, we saw a couple today actually, and whenever there's an ACL tear, especially a sizable one, there's a large area of fluid or effusion surrounding it. So we have a lot of little findings that would lead us to the ACL tear. And then, of course, being right here in the clinic, we can check the integrity, we can do a drawer test and just see how stable the ACL is clinically while we're doing the test. So that's what we're looking at deeper to the screen, is the anterior cruciate ligament. So we've talked about medial knee problems, medial collateral ligament, medial meniscus, joint surface, etc. That's what we're looking at here. There's also another thing called the PES Anserine bursa. This is a very, very common problem. And where you'll find it is right here where the tibia kind of flares up. So I like to put my hand down on the tibia right here and just follow it up, 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 boom, right to where it flares. And you'll run right into the PES Anserine bursa, right into the spot. Very common site for knee pain, and it's oftentimes confused with medial joint line problems, meniscus, medial collateral ligament. So with ultrasound, you can get right in there and take a look and see if there's a PES Anserine bursitis or not. So, there we go. And it's kind of right up into that zone. And this
tendon right there?
Yeah, that's a little bit, we're actually picking up part of the medial collateral ligament's distal attachment. And then when we roll a little bit more anterior, we're looking at 3 of the hamstring tendons that wrap across the semimembranosus, tendinosus, and the gracilis. They come in and they attach at this one point. Okay, so the bursa right here is a very common diagnosis. It causes a lot of knee pain and can easily be confused for a lot of other pathology. So very quickly we go from 1, 2, 3. We're looking at a lot of key things. ACL deep in there, the fat pad. Now we turn our attention to the lateral joint line. In the lateral joint line, we have the lateral collateral ligament. We've got the lateral compartment. We have the lateral meniscus. We have the iliotibial band, which attaches right out here on the front of the knee. And so let's take a look at that. Again, the advantage of ultrasound is we're bending things and moving things around. So now we've looked at...
Nice that it doesn't hurt and you just get to...
Yeah, definitely. If you do this right here...
You don't have to gown up or anything.
No gowning up. Yeah, right on the spot. Now, in this particular case, and we've looked at this knee before, so I kind of knew what to expect. There's a chronic injury. There's an old injury here on the outer edge of the tibia. And it looks like it's kind of developed into a little bone spur. But on the screen, you'll notice there's a little protuberance that's coming down there. And one of the things I like to see with ultrasound, and if you take a look and you keep your eye on this little protuberance right there, that's what we believe is a bone spur that's developed after an old contusion or something years ago, a sports injury. But you can tell, you can see when you move the knee that the lateral meniscus, which is that little wedge in the middle of the joint, and also there's a little artery you could see back there called the genicular artery, and it's a great way to identify the lateral meniscus. But with some dynamic motion, we could see that bone spur kind of digging in a little bit or causing a little bit of irritation. I don't think that there's a lateral meniscus tear because the lateral meniscus looks really good, but I can see where that bone spur might be causing a little bit of friction or kind of digging in a little bit to the lateral meniscus. There's excellent joint surface. So there's excellent joint surface. There's a relatively intact lateral meniscus, and the only thing we can see here is this little jagged bone spur that could be causing pain during running or different sport activities. And we can see that in real time here as we watch it and maneuver it and whatnot. The iliotibial band is coming across. This is another very common problem. You get iliotibial band syndrome, where you get a chronic swelling and inflammation along the IT band. And here you can both palpate it and then look at it with ultrasound straight into its point of attachment, which you'll see right up here along a little tubercle in the front called Gerdy's tubercle.
Yeah, I'm always amazed how close it is to the meniscus right there.
Very close, and that's what makes these diagnostic findings very challenging, especially with an acute injury that happens and now you're looking at it right after and you have decisions to make. You want to be able to quickly separate these things out.
Yeah, I definitely find that with lateral knee pain, especially with with runners, they always think it's IT band issues, but every time I look, I'd say 9 times out of 10 it's a meniscus injury on the side. But because it's so close to each other, you know?
Definitely, and the symptoms are very similar, and it's tough. It's tough to gauge. A real skilled clinician can isolate these injuries and really elicit the proper symptom, but it's difficult. So right away we could see in your knee that that's the only thing we have abnormal is a little bone spur that we believe is there. We'll have to get an x-ray. This would be a great thing to get an x-ray and confirm it. I don't think so far there's an MRI needed for this knee. There's nothing that we've come across that's out of our grasp at this point. But I do want to show you something in a moment that we looked at a little bit earlier, and that's up here in this region. This part of the knee is called the suprapatellar region, the suprapatellar recess, above the patella. It's a common place to collect fluid. It's a common place to collect loose bodies and fragments. You have the quadriceps tendon that attaches right here, and there are a lot of different scenarios that could go wrong in this spot. So when we take a look in here today, right now on the spot, one thing I was quite surprised to find is that there is a considerable amount of joint effusion in this suprapatellar recess.
So that's that black stuff.
Yeah, this black stuff right in here is definitely increased effusion, probably about 10 cc's or an entire vial full of fluid that really doesn't need to be there. And you can see when I move it around, you could see that tissue, which is some synovium, some synovial tissue, and you can see it flapping in the breeze there, flapping within the fluid. It almost looks like some kelp in the ocean or some seaweed. But this is definitely an aspiratable knee. But in an interesting way, there are no symptoms here. Normally, a patient will feel a tightness or a limited range of motion. I can actually feel a little crepitus with my palm as I have my hand over your knee.
Yeah.
I could feel a little creaking and some crepitus going on, which is typical with this kind of fluid.
So what kind of conditions usually go along with this type of finding?
You'll find this oftentimes with internal derangement or things like meniscal damage or any type of problem in the joint will cause a pooling or a collection of fluid up in the suprapatellar. The fluid has to go somewhere. So it doesn't really have much opportunity to go anywhere on the medial or lateral side of the knee. A common place for it to go is to drain to the back and to fill up in the bursa, the popliteal bursa, or the gastrocnemius semimembranosus bursa, which is right about in here. That's a common place for fluid to collect, and it develops into a Baker cyst. And in this particular case, we have a great view of the popliteal artery, which you could see here. And there's a very normal popliteal fossa. Let's come back to that. Thank you. All right.
I was ahead of myself.
That's okay. You got a little excited. So all we're doing is taking a look. Baker cysts.
Yeah, go ahead.
Baker cysts are very common. And a lot of times they're not a guaranteed. You think there's a Baker cyst and you're just not 100% sure. Get an ultrasound transducer and look inside of there instantly. And in this case, we could see a very healthy popliteal artery and vein. You can see the different popliteal vessels and absolutely no sign of a Baker cyst. So in your case, the fluid that is in excess in your knee has chosen to kind of migrate and pool up here. I think this fluid has a couple of sources. One, the changes that we saw along the lateral part of the knee and the little bit of grinding and bone spur that we saw. There is a history of a contusion out here, and there's probably a long-standing injury that could be the culprit for this fluid. Another possibility is we know that Dr. Sebastian's aggressive with the sport. He plays a lot of baseball. You're playing it.
Yeah.
So he's sliding. He's playing pretty aggressively, and you just played over the weekend.
Mm-hmm.
So the fluid in this knee could come from just a lot of an already weakened knee out here, and now there's some trauma going on and sliding around. But it's definitely not something that we see every day. And in our orthopedic center that we work in, they would drain this if they were going to do a knee injection. They would probably aspirate that first.
So how on a normal knee then would we see that black at all, or would you see just less of it, or?
You'd see a little trace of some joint fluid and there's a little suprapatellar fat up there. There's a little area of fat that sometimes has a darkened, hypoechoic is the term we would use, appearance. But this is...
You're just playing with it.
I know, that is... this is definitely not something that you should see on the average patient. So there's some reason going on here. The quadriceps tendon looks good. It kind of comes across here and attaches up top. So there's no problem with that. It's a common site for bone spurs on the suprapatellar pole or the upper edge of... That's probably the most common thing that we see in a knee. And this might be the most beneficial thing for people watching this that have knee pain, is the most common thing that we see is a syndrome called patellofemoral syndrome. Patellofemoral syndrome is when the cartilage behind the kneecap wears down and starts to thin out, and the distance, the spacing between the kneecap and the femur underneath diminishes. And as that space diminishes, you start to get some friction that goes on between the two objects, the two structures, and that friction creates pain, it creates fluid, and that might be the other culprit to this fluid up in here, is there's probably some patellofemoral issues going on. So we'll have to take a look into that. One of my favorite ways to see that is to bend the knee up like this, take the transducer across, and when you put the transducer across, let's see if we can get a little bit more of a bend like this. You can wedge it in like that.
Yeah, doing a lot for the camera.
Yeah, there we go. And you can see a very nice view of what's called the femoral trochlea. The femoral trochlea is a little groove in the top of the femur here, and it has a very thick articular cartilage, which we can see very nicely here, and we can see that this articular cartilage is very healthy actually, and there's no real cartilage defect or wear and tear to that.
So would it just look more narrow then?
Yeah, you would see, instead of a nice thick healthy layer of cartilage here, you would see it thinned out dramatically. On an elderly patient in their 80s or 90s, you might not even see that cartilage at all.
Yeah, so you'd see this kind of thing with runner's knee, or you said patellofemoral pain syndrome?
Yeah, patellofemoral pain syndrome. And what I like to do here is not only take a look at the femoral trochlea, but I like to angle the transducer and try to get underneath the kneecap at least and see this edge right along here and look for changes adjacent to it. A lot of times we'll see a fragmented appearance or little fragments and chips that represents the cartilage that's broken up behind the kneecap. I don't see too much of that here today. Ultrasound is not the greatest for looking behind the kneecap. We have a limited window into that particular area, but the results of it and the breakdown of the cartilage on the trochlea, and we do get a decent view at the top. So here we spent a good deal of time talking, but this whole exam should have taken about 5 to 7 minutes. So if we were just going through this in a normal way, there'd be no talking here, and we would just be making our way around the knee, and in a matter of minutes we can come up with some really good answers. We can find out what we're dealing with and where the treatment course should go. And if we're looking face to face with a blown out meniscus, then we need to know that right off the bat. Is this something that needs to go to orthopedic, or is this something that could stay in here and be rehabbed, so we're not wasting time and spinning wheels?
Good stuff.
Yeah, so that's a little tour around the knee.
So with everything you looked at already, is there any, you said just because patients will probably want to know, is there a need for an x-ray in this case that we have here? And is there a need for an MRI, and what are we looking for in those versus what we just saw?
Okay, now x-ray is x-ray, and in many places go right to x-ray just to have, because x-ray gives a good overall view of the joint. From our experience looking in at this knee, the only thing I would expect to see on an x-ray, there are two things I'd want to see. Number one, I'd want to confirm this little spur on the outer part of the knee. In your case, you don't really have too many symptoms there, so we're not going to go too crazy. And if you were the actual subject here that we were working with, probably we wouldn't need an x-ray because you're really not very symptomatic. we feel pretty confident that there's a bone spur here. But if your pain really persisted along this outer part of the knee, then we might want to step up and get an x-ray to validate what we think we're seeing on the outer part. Now the x-ray can miss things too. We're finding more and more that sometimes at off angle, you can miss little things even on an x-ray. The next thing I'd want to see on the x-ray is how does the spacing look behind the kneecap? Because an x-ray shows that really, really well. And you can see how diminished the space, or is it bone against bone, or is it wide open? So you get a little better perspective of that. So in this particular case with you, I don't see any need personally for an MRI at this point. There's nothing really to warrant that. I feel very comfortable with the effusion that's up here. If we were going to aspirate it, I would expect no less than 5 cc's and probably as much as 10 cc's of fluid to come out of here. And we would get it too. So I don't see any need for an MRI at this point, so we would put that to the back burner. But if this thing persisted and the pain wasn't going away and there was instability going on, we might want to look into it a little deeper and then bring an MRI in for that.
Yeah. Well, it's definitely nice to know that then this is a rehab case,
Yeah.
unless it goes poorly, and then we can look further to other imaging.
Exactly. Take it in progressive steps without jumping the gun. And sometimes the MRI can, if you pull it in too soon, it could sometimes upset the balance, because you bring in an MRI and it comes back normal. That now there's a little catch-22 here. We brought it in, it's normal, but the patient's in pain. Sometimes the normal MRI is enough to close the door, especially if it's a med-legal type of a case. You get a normal MRI and it's game over. There's nothing wrong, the knee's good, when in reality there could be something wrong. So you have to be very particular with when and how you use some of this imaging, because it could come back and backfire and kind of hurt things if it's not ordered properly.
Well, there's actually, I have a podcast coming out. I don't know what number it's going to be. It's going to be in the mid-50s, but it's on functional versus structural pain.
Okay.
Reasons for it. So, like, if you have negative imaging, you still can have pain, but we have to figure out why, and it could just be the way you're functioning. Yeah,
so there could be something as simple as an IT band, little strain that's going on here. It could be something as simple as a PES Anserine bursitis. And as we noticed when we first looked at your knee, you had a little bit of a bowing, a little bit of they call that genu varum. And although that's a normal variable in a genetic type of a...
It's a Forrest Gump head, right?
Yeah, Forrest Gump, that's right, he did it when he was running. But we've learned that this little bit of a sway, and you ironically have an issue on the outer part, it could make the outer part, the lateral side of your knee, a little bit more vulnerable, especially if you're a runner or something like that. So we're always looking at, when somebody presents with a knee problem that we can't quite figure out, we'll grab the patient's shoes and start looking at the tread on the bottom of the feet. We want to see what type of an imbalance might be going on. So your genu varum, although it's pretty insignificant, if you had real knee problems, we might want to enter this into the mix. Maybe there's an imbalance going on somehow that's causing an overload to the IT band, that's causing an overload to the PES Anserine bursa, or even contributing to this, what we think is a patellofemoral syndrome. You should be able to feel the gliding of the patella, and you can kind of push down on it a little bit as you rock it side to side, and you can feel if there's a rough surface behind. Sometimes you can actually feel that grinding. But in your particular case, I could feel a pretty smooth gliding of the kneecap, so I don't really feel any obvious chondromalacia or irritation to the patella.
Good.
So,
anything else you want to add on it then?
Just consider ultrasound if you have joint pain, particularly knee pain. Try to find a place that does ultrasound in a credible way and with a good experienced sonographer or radiologist. And ultrasound is an amazing tool that can help a lot of people. So I appreciate the opportunity to be here.
Okay, so hope that was entertaining, at least educational for you guys. I know that someone is going to bash that we don't have 2 mics, and that is too bad, because these transducer things cost a lot of money, and that's too bad. So we're doing 2 mics, or 1 mic on this. So if you haven't listened to the podcast already, you really, really need to. It is, I believe it's going to be in the low 50s or high 40s. So it's going to be on diagnostic ultrasound of the knee with Mike Jablon. So we're going to put his contact information below this video. You can also find in the show notes too. And if you haven't subscribed already to this channel, please do it. It's in the bottom corner down there. And also, too, you can subscribe to the iTunes. We'll put a link on the page as well, page below. If you have any knee conditions and you want to see another ultrasound on something like this, just put a comment below on your iPhone. It's all the way at the bottom. Just scroll past all the suggested videos, and then we'll try to answer them as best of our ability on another podcast or on another video like this. So take care, guys.